This is the MR imaging of a middle-aged female patient displaying skull-based defect at the fovea ethmoidalis with a protrusion, most likely a meningocele, inside the ethmoid sinuses, the anterior ethmoid, and the patient is presented with a profuse watery discharge from the left side nasal cavity, which is spontaneous and sudden in onset with no history of trauma. We proceed with the left-sided exposure of the fovea via the middle meatus route. Since the defect is in the fovea ethmoidalis and not the cribriform plate, we choose to retain the middle turbinate and do the middle meatal dissection, and we begin by doing an uncinectomy. Since we are to expose the base of skull, we make sure that the uncinate is fractured right till the axilla of the middle turbinate with no fragment remaining at the superior part to give us an unhindered access towards the ethmoidal roof or the fovea. If this were a cribriform plate leak, we would have to generally remove the middle turbinate for a better access, but here we seem to manage without the same. Once we have removed back fractured the uncinate, this is just trying to open the maxillary antrum slightly with a frontal sinus curette. And then, as a standard procedure, just like we do in an endoscopic sinus surgery, we use a fine 45-degree angled through-cutting forceps to resect the uncinate process flush with the lateral nasal wall right till the superior aspect of it. An important part here is to make sure that we do not resect the axilla of the middle turbinate itself, because then that makes the middle turbinate floppy and makes it much more prone for lateralization, causing eventual sinusitis in the future. As you see here, the removal of the uncinate process flush with the lateral nasal wall right till the superior most attachment gives us a very good vision of the entire middle meatus area and the ethmoid. And we use the same 45-degree or a frontal sinus curette or a ball probe, you have that, to back fracture the anterior ethmoidal cell, that is the bulla ethmoidalis, and resecting it with the back fracture always is the most safest way of removing it. When you try to use a black sleeve forceps, you can actually injure. And as soon as you remove the bulla, you start seeing the meningocele right in front of us, protruding from the fovea ethmoidalis. So this shows us a very clear correlation of the imaging, both the CT and the MR imaging, with the intra-operative findings, that is a clear-cut meningocele protruding through the fovea right just behind the bulla ethmoidalis in the anterior ethmoids. Now that we have identified the meningocele right in front of us without having to dissect a lot, the main focus would be to clear the excess redundant mucosa and dissect the cells around, and to create a bed which is both flush as well as raw for acceptance of graft material, whether that is fat or fascia. In this case, we plan for fascia to be used as a reconstruction material. So here we switch to our standard 0-degree microdebrider shaver blade to remove the excess mucosa onto the lateral nasal wall and the anterior ethmoids. One must be cautious here because the shaver is a very powerful tool with a powerful suction, and in such situation when you have a meningocele right up front, this must be used with caution and with the blade always under vision, so that we do not inadvertently puncture the meningocele. Though it is still to be repaired, the leakage of CSCV is not so much of a concern as it would be an inadvertent opening of a vessel that could be lying inside loose the meningocele. And then these vessels are notorious to retract inside the cranial cavity and cause bleeding, which would definitely create a lot of problems. So while the shaver is a great tool here to enlarge the maxillary antrostomy, remove the excess bony chips, the redundant mucosa over both the ethmoids, the antrum opening, as well as surrounding the defect, it must always be used in caution with a very precise hand control and foot control, with the blade always in vision, and in case the bleeding is a little uncomfortable, the field is not good, it is highly recommended that the field be first created the field must be optimized before proceeding further, as any error in this step of surgery could compound to create a lot of difficulties eventually at the time of actual repair. So we are focusing here right now on creating a wide access to the surgical space so as to give our graft material ample amount of bone to lie on, hence clearing of all the mucosa and excess mucosa fragment in the bone. Since the defect is very clearly in the fovea and is well visible, it does not seem required to open the sphenoid in this situation. We are barely opening the basal lamella here, just to get access to the posterior ethmoid, so that the entire defect is right in front of us and we can make the skull base flush for our surgical repair. Here we see that as the basal lamella was penetrated, now we are just breaking the septations using a frontal sinus curette to gain access to the meningocele both anteriorly and posteriorly. The anterior axis already is there, and this is just to create a posterior axis so that we can ablate or coagulate the mucosa and the bone posterior to the meningocele as well, for a sure shot acceptance of the graft material. So once again, we prefer to use our cold instruments or black sleeve forceps to remove bony chips, and prefer to use the shaver on the excess redundant mucosa while maintaining a distance with the meningocele. In case the excess mucosa is very close to the meningocele or is practically in contact with it, then we would recommend to not use the shaver, and in that situation shift to the coagulator, because the shaver would eventually inadvertently puncture and create potential problems. So we see here that we are using a blunt dissection to break the bony septations to get behind the meningocele comfortably and to clear all the excess bone and mucosa while not penetrating the meningocele. Meningocele, of course, as we all understand, have to be either coagulated using bipolar forceps or coagulation wands for them to contract and to make sure that any vessel loops inside them are closed before we can resect them. So once again, we use the shaver to trim off the excess mucosa adjoining the meningocele as well as around the lamina papyracea. What must be clearly understood is that one must definitely take some time in obtaining adequate exposure in this stage of the surgery, because any haste here or trying to plug the defect without creating adequate exposure and raw area has a much higher chance of failing eventually, and these failures are known to occur even in a delayed fashion. It may not be apparent initially as you have packs and gel foams in place, but after a few weeks this can turn out to be a failure if adequate preparation has not been created while operating. Some excess mucosa and bone around the frontal recess area is also trimmed carefully to be able to again achieve an unhindered access with a 0-degree scope towards the entire meningocele and the fovea defect. The meningocele is not a concern. The concern is the fovea defect. The fovea defects are small and the meningocele is big, but as soon as we coagulate or ablate it, we would have to precisely locate the defect for precise closure. Now, as we see, most of our excess mucosa and this bony septation in the ethmoids have been considerably cleared. with a clear view of the lamina papyracea, and as well as the completely open posterior ethmoids, the middle turbinate. Here we take a hedgehog Koffler punch to remove some more bone in the area of the frontal recess or the posterior wall of Agarnesi to further expose the anterior portion of the meningocele and hence the fovea defect. So it's strongly recommended that we use either a hedgehog Koffler bone punch in various angles available, or sharp angle true cuts to remove the bony septations, and not use Blacksley forceps to torch, because in that process we end up pulling and tearing the mucosa and might also start create a pull on the meningocele, which would be disastrous. So as we approach close to the meningocele now, with all the mucosa hugging, we shift to our cobblator wand. This is an EVAX 7-3, a standard arthrocare coagulation wand. And as you see here, we immediately put it to use by on the coagulation mode initially on the meningocele, and as soon as we do it, it immediately, as you see, shrinks the meningocele and brings a much more perspective into the picture, because our purpose is not the meningocele but the skull base defect through which it is protruding. Now we see that we are using right now initially the coagulation wand on the coagulation mode, but later on, as we see that the meningocele has shrunk, now we shift to the ablation mode and we immediately start making all the mucosa around the skull base defect raw by ablating it with the coagulation forceps. And we are also at the same time ablating the meningocele proper, which has been shrunk. Now since it has been shrunk and enough amount of coagulation has been used, you could be fairly certain that we are not missing any vascular loops here, and using even the ablation mode on this meningocele can be considered reasonably safe, since our exposure seems to be adequate. So we continue using the coagulation wand on the ablation mode to ablate the entire roof of the ethmoids. In fact, even as well as the mucosa on the lamina papyracea towards the superior aspect, as well as the superior aspect of the lateral middle turbinate mucosa. So all in all, this is very safe here, because unlike a shaver, which can sometimes protrude and penetrate the skull base, the coagulator does not penetrate the bone, and hence even while working on the skull base, it's an excellent tool because it offers control as well as this slight bend of the tip, which comes very handy in making contact with the angled skull base, even with the 0-degree forceps endoscope. So as we see here, it practically takes just a few minutes for us to ablate the entire surrounding mucosa around the skull base defect, as well as the meningocele, and to create a fair amount of raw area for eventual graft placement. Some excess bone chips can be removed, cold instruments, as we can see here. So the point is that the entire preparation for grafting must be made clearly, and hemostasis has to be achieved to be made sure. There's no bleeding, no oozing, no excess, no pieces of thin fractured bare bone, no excess mucosa to lead to mucocele formation. So it's very important, and it's imperative to be sure that we have nicely and completely ablated all the mucosa around the skull base defect, and much more in excess of it, because we anticipate 2 layers of graft here. One would be an inlay and the other would be an onlay or an overlay to cover the first graft. So much more bone would have to be made bare as compared to simply the size of defect. Also, since the defect size is small, we would need to enlarge it slightly with blunt instruments before we can place a graft material. It is nearly impossible to shove in a graft material through a very small defect. So even if the defect looks small, it is important to ablate much more mucosa around it and create a fair amount of flush bone without any septations for adequate reconstruction preparations. So we see here we are again ablating and possibly the ethmoidal vessels also, coagulating them and ablating them turn by turn so that we do not miss any vessels here, and the entire base of skull around the fovea defect is made bare. So once again, now we are just using coagulation mode again and again on the defect proper, on the erstwhile meningocele that has been reduced and is now no more in picture. The coagulation wand also allows us to palpate the skull-base defect throughout to coagulate it nicely, because otherwise the moment this is contacted with our elevators, this could lead to oozing or bleeding from the dural vessels if the area is not well coagulated. This step can be achieved either using a bipolar forceps or the coagulation wand. The normal bipolars don't really go there very well, so one has to use endoscopic bipolars. But the advantage with the coagulation is that we get irrigation, suction, coagulation and ablation, everything in a single tool, and thus it allows us even a two-hand technique very, very easily without resorting to more hands inside the surgical field. We see here that we are just trying to make sure that we're not leaving any mucosal bits there, which could lead to lack of adequate adherence of our future graft material, or lead to formation of mucoceles. So we are taking all the measures here to ablate the entire mucosa around the defect, and much more probably for our proper reconstruction. So now we can see how the lamina papyracea is practically bared, at least in its superior half, around the defect site, as well as the corresponding surface of the middle turbinate mucosa. And now we are just using more and more coagulation on the skull base defect and the exposed area proper, so that any contact here would not lead to unnecessary bleeding and contamination of our surgical field. So the fundamental part that we always believe in and we propagate here is that the bleeding is not a much concern here unless it's an intracranial profuse major bleed. Our concern here should always be our surgical field. Our surgical field in all these reconstruction patients is sacrosanct, it's paramount, and I cannot understate or overstate the amount of time you can spend on getting a good surgical field before we resort to actual repair. Now, once this has been bared, we're using here a navigation probe to once again reconfirm our site of defect, because the meningocele has been removed, and it is our practice to always use intra-operative navigation in these patients, because once the meningocele or the encapsulocele have been reduced, the skull-based defects can be small sometimes and they could be confounding. So to have an intraoperative navigation probe point to the exact place of defect is actually quite helpful. It makes the surgery more precise, the outcomes more consistent, and if it is available in the theaters, it must always be used. There is no excuse to not using it if you have it available. Though it's not compulsory, one can definitely close these defects without it as well. But presence of them in the OR should be considered as a mandatory indication to use them as well in these patients. It is also a very good teaching tool, as it can reinforce towards the entire team, whether it is ENT or neurosurgery or residents in training, that this is how the defect is, this is where we are, and this is how it looks once the meningocele has been shrunk or excised. So now we're using a double-angled elevator to point to the exact site of defect in the fovea ethmoidalis, as well as to slightly enlarge it, because as I mentioned that very small defects are nearly impossible to repair. So we definitely have to remove some more bone in the defect area to enlarge it, as well as this gives us the opportunity to create space between the bone and the dura for eventual placing of our graft material. It is obviously borne in mind that actual underlay grafting, which is done above the dura, is very difficult in these patients because the defects are small. One could never go inside the dura in these patients. So our primary or the first layer of facial graft material would actually go between the dura and the bone. And for this we could use various kinds of angled elevators to work on the skull base, like we are doing so in this patient. And the point is to remove some bone. One must never be scared of removing excess bone as well, because it really does not matter as long as you have adequate exposure and 2 layers of fascia, which is inlay, you can say, and onlay. These defects are almost always closed until unless there are other factors that could hinder them. So one must be very generous in removing some bone around the skull base defect area to create more space. And as contrary to popular thinking, it is easier to place graft materials in larger defects as compared to smaller ones. In smaller ones, our graft materials or our fascia is bound to get curled on itself, not be taut, not be straight, and hence would always lead to poor outcomes. We can see here that the thin bone on the skull base is being removed slightly, chipped off. And now as you can note also, we have shifted to a 70-degree angle endoscope. We are looking at the defect from below, and for better maneuverability, this is our a routine step that we follow. Once we expose initially with a 0-degree scope, for the final reconstruction part and the final part of elevation of dura or the bone, we switch to a 70 endoscope because that gives us a very clear vision of the skull base. The only issue being that with the 70 scope, you need to have angled or sometimes double angled instruments to be able to work at that place, because straight instruments would often not be able to achieve that kind of access. We see here we have taken a measured portion of fascia lata to be the first layer that we want to insinuate between the dura and the skull base bone for closure. We could use we're using a double angle elevator, again the one that was previously used, to try to insinuate and push gently all around this fascia graft as a sandwich between the dura and the bone. This step is also though it's possible with a single hand, we do recommend that the scope could be handled by an assistant or your colleague surgeon while both hands could be used more effectively in insinuating this fascia, so that it takes less time and becomes less frustrating of an exercise. So appropriate sizing of these fascia grafts is also fairly important. Though it must not be undersized, but oversized grafts will never be able to sit in these small defects. So it must be borne in mind very carefully that the grafts must be sized. You can size them by using a frontal sinus curette, measuring appropriate size, or by using a suture material to see the suture material packing to be able to measure approximate sizes of the graft material. So as we see here, again we are using a 70-degree angle endoscope pointing upwards for a clear vision, and we use an angled elevator in this situation for gradually and slowly pushing the fascia lata within the boundaries of the dura and bone. So as we see here, the fascia lata has been reasonably well insinuated between the layers of the dura and the bone, with just the final portions being done to confirm the fact that it is inside all around and no part is left open, because whichever part is left open could become a site of a CSF leak. As we can see here, we are attempting to use a frontal sinus curette, but this does not appear to be the best instrument for this part because of its bulky size. It is best to use elevators, either skull-base elevators or curved elevators for this purpose. And we strictly don't advise the use of ball probes here, because ball probes almost always pull back the fascia that we have insinuated in between these structures, and is strongly not recommended for this step. Flat, blunt elevators are the best instruments for this part. We again do not recommend either ball probes nor any sharp elevators. This is one step which does require a fair bit of patience. One must not give up patience here during this step. It could be many a times that the graft starts to come off from one portion of the reconstruction part as we try to pull or push the other part, and one may need to have frequent adjustments to be made to be very, very sure that all the entire graft is located inside the bone and outside the dura, and not lying outside, because that could result in eventual failure. Now, as we can see here, our facial autograft has been reasonably well positioned, and this has been now completed with the use of another facial autograft as an overlay sort of fashion. This is above the earlier reconstructed fascia, and this is on the bone, on the bone, just on the earlier fascia material. Now, this facial autograft, of course, has to be much larger than the previous one, because this has to ideally cover much more of the raw bone over that area, and that was the reason why we ablated much more bone than the size of defect for this fascia graft to be able to adhere to the bare bone. Now, fascia requires bare bone for adherence. It does not get adhered to mucosa. Hence, it was imperative that all mucosa be removed from much more around the size of defect for this fascia graft to be taken up. It's also very important to not use any glue between these two fascia grafts. Here we're using tissue glue, but this tissue glue is used on the final layer always, and not in between the layers, because then if we use in between the layers, these layers will not get adequately adhered to each other, and then our purpose of reconstruction is lost. So whether we use 1 layer, 2 layer or 3 layers in skull-based reconstruction, we strongly recommend that all these layers be used one upon the other without any glue in between, and glue be used only in the end on the final layer, whether it is a free mucosal graft on the middle turbinate or the fascia graft. But we always recommend that be used in the end on the final graft material and not in between the various graft materials, because that could lead to failure. As we see here that our graft has been well set. It was all on the bone. We had removed practically all the mucosa inside that region, so it is well placed and well set with the use of tissue glue, and all that seems to be left now is just trying to make sure that the edges are well in contact with the bone. We do not want, just like in tympanoplasty and with other grafting techniques, we do not want the fascia to roll onto itself. That affects the adherence. We are here also making sure that the entire graft material rests nicely on the bone all around, and does not fold on itself or lie on mucosa or any mucosa gets buried, because that leads to mucocele formation. Now, once this has been done and tissue glue has been used, we could just cover this assembly with either Surgicel or gel foam. If we would have not used tissue glue, we could have used Surgicel for better adherence to the bone. But here, since we have used a tissue glue, we would straightforward proceed to placement of gel foam layers on this graft material to be able to give support to this, as gel foam does absorb much more than its own weight in water and saline, and helps in eventual adherence of this graft to the bone. So using 2 layers for such kind of smallish defects is reasonably good approach, and we normally use only these 2 layers. The second layer, which we have used as an overlay, could be also replaced by a free mucosal graft. So we use that when we plug the defect of the capiform plate and use a free mucosal grafts. But here, since we maintained the middle turbinate and did not resect it, we preferred using another fascia grafts over the first one. The 3-layer fascia graft, that is, one is underlay, that is above the dura, the other inlay on the dura, and the other overlay. This 3-layer technique is normally we only use it in repair of much larger skull-based defects, as the ones that are created surgically for removal of olfactory groove meningiomas or esthesioneuroblastoma, and hardly ever in spontaneous CSF leaks. So as we have given some time for the tissue glue to set over the our fascia graft on the bone, we can now begin placement of some gel foam layers over this assembly to help it in setting. So roughly 3 to 5 minutes is what we normally give to this tissue glue to be able to set and form sort of a thick layer over the entire graft material, and particularly the edges of the graft to the bone. And once we have seen that it has been 3 to 4 minutes or 5 minutes, then we can simply proceed to closure by placing 2 to 3 layers of gel foam over this assembly. Here we use compressed pieces of long gel foam strips. We do not prefer to use small gel foam fragments the kind of way we use in tympanoplasty. Here we want to use longish films which can cover the entire defect and much more area of reconstruction from bone to bone, so that it helps in immobilizing our graft assembly. So once again, rather than using any Blexley forceps that tends to pull them back, here we use the same curved elevators, broad blunt elevators, to create a layer of gel foam over it. Gel foam also, one must understand, induces fibrosis when it is in contact with the mucosa, which in this situation appears to be good and handy and to our benefit. In normal sinus surgery, we abstain from using gel foam, again because of its fibrosis causing properties. Here, in situations of closure of skull-based defects, fibrosis comes to our rescue, as it would help in creating more enduring repair of the leak. So as you see here, we have the gel foam, and its size has been tailored, has been reasonably well covered in a single sheet from the middle turbinate to the lamina papracia, right from the frontal recess to the posterior ethmoids, thus not letting any portion of the reconstruction portion to be exposed to the surroundings or to the back.